My name is Henrichsen. I am a radiologist at Mayo Clinic in Rochester, Minnesota, and this next talk is really neck imaging with multimodality correlation. I have no disclosures or off-label use to discuss. What we're going to try to do here in the next 20 minutes is to review what techniques we have available to us to evaluate the neck, including looking for parathyroid and thyroid glands, as well as some postoperative change. We already had a great overview of that, so I'll limit that as well. We're going to discuss the goals for ultrasound in patients that have had previous cross-sectional imaging studies and trying to rationalize and correlate those findings, as well as with nuclear medicine studies. And we're just going to discuss some cases where multimodality imaging really provides added value and when we need to ask for those studies and follow up on them. So again, the most important thing for us is really to determine that correlation and make sure that if we're doing ultrasound after other imaging, we are correlating that and making sure that all the findings that they were worried about we see. And the same thing when we refer off those cases to do that follow-up, because we can learn some really valuable things when we send cases off to other studies. I do have lots of examples today. We're just going to go through a lot of a case review, including CT, 4D CT, MRI, nuclear medicine studies, including multiple types of PET imaging, and some correlative ultrasound imaging. Now, I think most of us know that we get a lot of our cases from CT. Typically, that's when nodules are identified on the CT exam. We see them sometimes for really asymmetric thyroid glands or non-uniform enhancement. And what we do know is most of the time the CT is not really helpful for us to help our patients on what we're actually seeing, and it's the ultrasound that really gives the most information. This is just a typical example that we received in ultrasound showing a contrast-enhanced CT demonstrating a lower enhancing region in the central portion of the right thyroid lobe. This particular radiologist put some ROI on it and tried to get a Hounsfield units. There's a lot of studies that have looked at this. It's really diverse. I don't know that it's replicable in a lot of institutions. Some people say that if it's greater than 100, 115, 120, it may be more worrisome, but in this case, the Hounsfield units was 105, and as you can see on the ultrasound, this was a colloid cyst. So it didn't really help us in any way to do that extra Hounsfield units assessment, and ultrasound was really the answer for this patient. Another example from CT that we've received, in this case we see there's an enhancing mass in the posterior right thyroid lobe, pretty much peripherally enhancing, maybe less enhancing centrally, doesn't show any invasion or any worrisome features. The next step should be ultrasound, as we know. This is the image we got from our ultrasound. Again, a fairly large nodule, underwent FNA because of size and criteria, and this was also...
Thank you very much. Good afternoon, everyone. I'd like to thank the organizers for inviting me to speak, and I have no relevant disclosures. Ultrasound, as I'm sure you are all aware, is often the first imaging study that's performed in the evaluation of urgent medical conditions in children. And I'd like to review with you this afternoon the role of ultrasound in the diagnosis of several important pediatric disorders of the head and neck, chest, abdomen, pelvic organs, scrotum, and extremities. The first case I'd like to discuss is of a 3-month-old infant who was found unresponsive. And you can see that there is a large fluid collection overlying the convexities of the brain, and that the vessels are tamped down and compressed against the surface of the brain, and we don't see the usual bridging vessels, which is the hallmark of a subdural collection. And here we see a CT that was subsequently done that confirms those findings, and we also see that there is some parenchymal hemorrhage as well. And bone window settings show that there are multiple skull fractures. This was a case of a subdural hematoma in the setting of abusive head trauma. And brain and head injuries are the leading cause of fatal head injury in infants. And the etiology is multifactorial, some combination of shaking and blunt impact. Subdural hematoma is the most frequently identified intracranial injury, with the parafalcine location being the most common, but it is the brain parenchymal injury that is ultimately the major cause of morbidity and mortality in these infants. The next case is of a 6-year-old male who presented with fever and a swelling of the left neck. And you can see on these grayscale images that there are multiple enlarged lymph nodes that are hypervascular on color and power Doppler imaging. Their internal architecture is preserved, and there's a lot of swelling and increased echogenicity of the soft tissue surrounding those nodes with loss of the usual soft tissue planes. Evaluation of the right side of the neck showed similar, although less pronounced abnormalities. These findings were confirmed on neck CT. You see the enlarged lymph nodes. There is some fluid around the nodes on the left side of the neck. And this is a case of cervical lymphadenitis, which is very common in children. It's usually viral in etiology with bilateral involvement and generally presents with a painful cervical mass. When the involvement is unilateral, it's frequently related to orifice.
So how many of you guys in the audience do contrast-enhanced ultrasound? I really wish that was everybody. How many of you guys use it for the gallbladder? Excellent. I think this is one of the most fun applications of contrast-enhanced ultrasound that I have found. I love doing the gallbladder because it's often seen well by ultrasound, which means you get beautiful images. But beyond that, I think there are some incredible, impactful applications for contrast-enhanced ultrasound that are completely unrecognized or at least undervalued. And if you're doing contrast-enhanced ultrasound in your practice, you need to be doing contrast-enhanced ultrasound of the gallbladder. I do have some mandatory disclosures and a requirement to say that this is off-label. However, we know that's all kind of bullcrap. All right, so I'm going to start with two cases. A 30-year-old pregnant female with elevated LFTs in this grayscale ultrasound, and this 68-year-old woman with bloating in this ultrasound. Which one, if either, is a mass? And we'll come back to these. So my outline for the next few minutes is talking about the normal gallbladder appearance in contrast-enhanced ultrasound, breaking up abnormalities into intraluminal abnormalities and wall abnormalities, and then finish with a few cases of gallbladder intervention. So why contrast-enhanced ultrasound? I don't need to belabor the point with this group, but for anyone who has been under a rock the last few days here, I love to see all the contrast lectures and shout-outs at this meeting. That's fantastic. Obviously, we can do contrast in ultrasound when you are unable to or unwilling to do contrast in CT or MRI. As our agents are cleared by the lungs, we're not worried about liver or renal toxicity, very low reaction rates and few contraindications, allowing us to do this basically at the drop of the hat in almost every patient in every condition and do it multiple times in a row. So contrast-enhanced ultrasound, unique modality, and I want to focus on this because it has applications for what we're going to be talking about in the gallbladder. So bubbles are a pure blood pool agent. There's no extravascular interstitial phase, and they're rapidly cleared. So that combined with the ultrasound bubble interaction, you get exquisite contrast to background. You can do high-tempo imaging. And using these microbubbles, which are purely intravascular, basically anything that enhances is perfused. And anything that is not perfused will not enhance. And we see that with scar tissue or inflammatory tissue in CT or MRI because of this extravascular interstitial accumulation of gadolinium and iodine-based agents. Whereas with microbubbles,